Welcome to Big Ideas in Overdose Prevention. Build partnerships that work. My name is Jeff Bornstein, and I'll be running this Dialogue for Health web forum with my colleague Merlene Tucker. Thank you to our partner for today's event, the National Overdose Prevention Network. And now it's time to meet the moderator of today's event, Dr. Carmen Rita Navarez. Dr. Navarez is the director of the National Overdose Prevention Network, the Director for Center Health Leadership and Practice, Director of Dialogue for Health, the Senior Vice President Emeritus, External Relations and Preventative Medicine for the Public Health Institute. Carmen, it's a pleasure to have you. Welcome.
Thanks so much, Jeff. Good morning and good afternoon. Welcome everybody who's on this call with us. We are really pleased to bring this next in the series on partnerships, building partnerships that work, part of our Big Ideas in Overdose Prevention series. For those of you that wondered, in case you thought you were seeing something unexpected, we did have a change of speakers today. So instead of Courtney Lovell, we're going to have Josh Luftig, and I'll introduce him in a minute to you so that you can get a little bit familiar with what he is doing and who he is and what he brings to this conversation. So let me have the next slide, please. Let me start by talking a little bit about what we're hoping you'll walk away with from this meeting. We want to just identify an opportunity for you to be thinking about how you create new partnerships within your community. So this is about learning a process. We want you to gain skills about how to build those strategic partnerships in your overdose prevention work. And would like you to identify strategies to integrate equity into your partnership building efforts. So some of this is a video that we're going to start with. Some of this is a conversation that I'm going to have between myself and Josh. And we're also going to ask you all to comment into the Q&A and help us to keep the conversation going. Give us some of your best examples or challenges, and we'll see what we can do with some of those ideas. Next slide, please. So this is, as I said, part of a series in 5 big ideas in overdose prevention. We have already seen reach people where they're at, be willing to pivot, don't reinvent the wheel. And today we're doing build partnerships that work. Next slide. Today's session is about forging partnerships that work. What do we mean by partnerships and why are they important? Working with other stakeholders can take different forms and often present a range of challenges and complexities. There can be conflicting agendas and control issues due to varying ideologies and strategies, particularly in such a complicated and stigmatized issue like substance use disorder. May I have the next slide? We know that stopping overdose deaths requires collaboration. It requires us to respond to community needs, generate dialogue between sectors, and focus on long-term solutions. It truly takes an all-hands-on-deck approach, which is why we use this wheel as a visual to represent just some of the many sectors that have a stake in helping to prevent unnecessary pain and deaths. Next slide. There are definitely some great tools and tips that we've provided to teams across the country in developing an effective partnership building strategy. First, your collaborative needs need to shape a collective vision and purpose among members. You need to decide which stakeholders are critical to include to get the work done, what are their perspectives on the issue, and you need to reach out to them and include them. You need to work to ensure all necessary stakeholders are involved to get the work done and acknowledge potential turf issues and challenges that could arise between members based on membership characteristics and organizations. It's important to have honest conversations about the history of relationships between organizations and to take the time necessary to develop trust between members. And you need to establish a decision-making process and structure. Decide how formal your structures and agreements need to be and how to ensure that everyone is heard when making key decisions. Openly discuss the intentions and the motivations for each member's participation and reason for being at the table, either as an individual or as an organization being represented. And be sure to set milestones and acknowledge success, because early successes help build commitment between members to the collaborative vision. The next slide, please. We encourage you to put a plan in place to take an intentional and thoughtful approach to your partnership strategy. Be sure to check out our partnership mapping tool, which you can find on the resource library on our website at www.nopn.org. We include a short video on how you can work with your coalition or other partners in order to use this tool, really utilize it in a way that we know has been tremendously valuable to communities across the country. Next slide. And go to the partnership site part of our website at nopn.org to find webinars, partner profiles, and resources to help you strengthen a cross-sector approach. I will take this moment to introduce our other speaker, and then we'll take 8 minutes to watch a video on partnerships, building partnerships that work. So it is my complete pleasure to introduce today's guest, Joshua Luftig. Josh is the Department of Emergency Medicine physician assistant, investigator and clinical instructor of emergency regional anesthesia at Highland Hospital, Alameda Health Systems, and Bay Area Regional Director for the California Bridge Program. Welcome, Josh. We're really pleased to have you today. So let's go ahead onto the video and watch and listen for the next 8 minutes, and then thinking about what we hear, let's start a conversation.
One of the things that I walked away with was the need for us to feel more urgently that this crisis has to be addressed similar to the way we have the COVID crisis. We have to not only rethink how we are providing services, but we also have to rethink the policies that we have in place that make it difficult for us to provide the innovative approaches that we heard yesterday could be so effective in helping people live healthy, productive lives and also deal with their substance use. And it was a challenge. I think we had a gauntlet thrown down that all of us, no matter where we're working, have an opportunity to change the way we think, fund, and provide services for substance use disorder and to prevent more overdose.
I know personally and intimately that in my own recovery, it was peers before they were called peers. They were peers in recovery who really showed me that not only was recovery possible, but living a successful life, having this great career was also possible. So we need to have this separate role within clinical spaces, within treatment, within community-based spaces, because the addiction counselors and social workers cannot deliver this specific messaging, but it's needed. So if we can help move the field forward, we can help train those clinical spaces, the supervisors, to have a better understanding of the differences in those ethics between being a recovery coach and being an addictions counselor. If we can train all the staff within those clinical settings to understand the value of the role, and then we can train all of the peers to have the same standard of training, then we can, I really believe, make a huge difference in the trajectory of this overdose crisis that we're in right now.
So what we do is we actually have a digital handoff. So EMS patients who are seen for substance-related reasons are digitally referred to the substance use navigator. They refer and provide referrals to MAT and connects patients to other county resources. And how do we do that? We do that digitally. We don't rely on anybody like making a phone call or filling out a page. It's all done electronically. The field medic documents their care as normal. And then we have a secret sauce, which is a company called First Watch, which does data mining of all of our records. And if it fits into our trigger, then the Sun gets an email on this case. Then the Sun logs in and is alerted for further follow-ups. So this is a trigger that is the data set can use multiple sources.
I think historically the state attorneys general first kind of came to prominence really with the tobacco master settlement agreements decades ago, and all kind of banded together. And there were some concerns about how the billions of dollars of that settlement ended up being used, because while they went back to the states, they sort of went for general use. They went to general funds. And in this particular settlement, the emphasis from the get-go has been, whether it's states or counties and cities, first of all, let's make sure that an adequate amount of funds is deployed to local municipalities because they're nearest and closest to the issues and problems. Certainly we need state programs funded, and there's a synergy having state and local funded together. So that's a critical component, and without getting into all of the specifics of percentages and everything else. Also, that the money would be focused primarily on avoiding another generation of addiction. So prevention, awareness, and then also to address treatment and recovery for those who are currently trapped in that cycle. I want to say this, one thing it doesn't address, and people ask me about it all the time, and sometimes I think they misperceive what the settlement is about. They say, it doesn't matter if you get billions of dollars back, that's not going to restore my son, or that's not going to bring back our loved one. You're absolutely right. There are no amount of money will ever bring back the life, and no amount of money is important or equal to an individual human life. That's not what these are trying to do. We've never, and the funds aren't going back specifically to families in terms of compensation for their loss. Where we, as I said before, really think that we can make the best impact and get the greatest ROI is building bigger fences at the top of the cliff, if we want to use that analogy, prevention programs. Because if we never have people getting addicted in the first place, it's so much easier to address.
And the first component of the community is the law enforcement sector. Law enforcement leadership needs to make sure that their law enforcement officers on the front lines have access to Narcan, have training on addiction, opioid use disorder, have the tools and resources to be able to refer somebody to get treatment outside of the law enforcement sphere. So probation and parole officers are regular points of contacts with individuals following incarcerations. This is a great linkage opportunity to get these folks to treatment for their opioid use disorders, treatment for their addiction. And our probation officers need to have the training and the tools to be able to provide this linkage. During overdose spike, social services and schools should be a part of an overdose spike response team. Their roles differ, but both have the goal of protecting children. Health departments need to coordinate within the overdose spike response plan because they have a role in evaluating have They can also provide support to local community-based organizations as well. State health departments, have resources at the state level, which can be afforded to local and community-led efforts in try to mitigating this threat.
Designing this meeting was an important team effort. We reached out to people across many different professional sectors to bring some of the best thinkers and doers to this meeting to share their work, their successes, and their lessons learned. We hope that bringing these two major themes of innovation and a focus on equity, justice, and fairness help to bring you the kind of content and the kind of inspiration that you need in order to do your job better, in order to help save lives across this country and hopefully around the world.
Okay, well, thank you so much for that video. I want to bring Josh up on screen with me. So Josh, having seen the video was part of a whole series of pearls of, wisdom from people who were part of the National Overdose Prevention Leadership Summit. And I think there were some really important things that were said there. I liked how they started at the peer level and then moved through policy, law enforcement, health departments, really just a whole series of different people that we need to get to the table. But with the work that you have been doing for, I don't even know how long, I can tell from our previous conversations that you're so experienced in this work. You've thought about this a great deal, but maybe you could talk a little bit about why you think these partnerships are important, just to get us started on this conversation.
Yeah, so it's one of these things where patients face, there's a lot of people in the community who are ready, they're for instance have opioid use disorder, and they are many people who have opioid use disorder are suffering sort of consequences of that and are ready to move on and quit. And when they look around in their community for resources that are going to help them do that, access to treatment, they find a fragmented system in our community. And so what we've found as we kind of ventured into setting up, primarily out of the healthcare system, setting up low barrier access to treatment and low barrier access to naloxone, that our patients were, even though, like when you start to set a system up in place in one location within the community, you start to realize how fragmented the system is radiating out from there as their journey goes from the hospital to the outpatient clinics, or they become justice involved and end up incarcerated, and all these transitions. Each step along the way is a chance for patients to just fall right through the cracks and end up without having support and services and a connection to a meaningful treatment. So that's where these partnerships come in, and then even within our hospital, there's so many players and roles, and as we move forward and start to implement one piece of it, then we realize that nursing and social work and all these other, pharmacy, everyone actually has a role to play internally within all of our organizations to help actually form a meaningful partnership that will serve our patients.
So give us a little bit of an idea of the setting in which you work, and how people with substance use disorder come to you, and how you've come to understand, given where you work every day, how important partnerships are.
Yeah, so I work in the emergency department at Highland Hospital in Oakland, California, and we've had a significant portion of our patients have substance use disorder. And what we've done, we realized at a certain point, we recognized that we were not serving that patient population well at all. That historically, emergency medicine does not have a great background in addiction medicine training. We were not providing any meaningful access to treatment. We didn't know how to dose buprenorphine. We weren't prescribing buprenorphine. We weren't linking people to outpatient care in any meaningful way. It was like, here's a list of treatment, this follow up here, but there wasn't someone who was advocating for them in a meaningful way. So we worked to build in that capacity. And a lot of it was listening to our patients, listening to people who use drugs, and really partnering with them, hearing the barriers they faced, and getting on their side and working to knock down those barriers. And also being, it's like the more we did this work, the more you get sort of frustrated. You start to see how many barriers exist. It's almost like the system is designed to make patients fail. Like people who are, even from, you give a prescription, they go to the pharmacy, the payer would not cover that particular, that pharmacy, they wouldn't have buprenorphine, they wouldn't have that formulation, and they would just not fill it, not recognizing that this was a life-saving medication that it was like not giving insulin to a diabetic. It was the pharmacies would, for the silliest little technicalities, would not fill prescriptions, as one example. So then we partnered with them, and and a lot of it, I gotta say, when you mentioned the peer navigators, we were able to create a position um, and hire substance use navigators, which are peer navigators, most of which have lived experience. And having that person positioned in the ED as an advocate and someone who can meaningfully connect with people who are coming in who are struggling with substance use disorder was so powerful for people to feel welcomed and greeted and heard and supported. And then having that person, actually that substance use navigator, continue to engage after the ED visit, make sure that when they get to the pharmacy, they can call, if there's any issues, any hassles, any problems getting to their next appointment, phone calls to remind them of upcoming appointments. All that ongoing engagement has been a game changer in terms of how we're able to serve this population.
So one of the things that I recall from our initial conversations a few months ago was that you really impressed upon me that in your emergency department, you all have formed a number of what I think are very strategic partnerships with people around you who aren't generally part of what we consider to be the healthcare team. So the healthcare team is the intake person who helps you be a part of the helps you get checked in, and the nurse who does your vitals, and the person who sees you first. That's what we sort of think of. That's the team. But there's a lot of other people in your environment that you've invited into your team. And I wonder if you might do a couple of things. One is identify who some of those non-medical people are, and then also talk about, how did you initiate that conversation? How did you get people to to talk about this, and how did you get them to engage and commit to being a part of the team?
Yeah, so there's, yeah, I mean, we started to recognize that, you can, it sort of radiates out. Like, you have the sort of early adopters and the people who are really driving this forward. But your whole healthcare system, including like security, when they come, if people are treating people with substance use disorder in a hostile manner, and carrying a lot of stigma and bias against this population, and they work in your hospital in any role, it can be devastating to people coming in seeking treatment. And it also, it's one of these things where people come to the emergency room for all different reasons, and what is driving, so they may come in for an abscess, but they're injecting heroin, and they may just come in for that abscess, or they may want to be ready to have that conversation around their substance use. And whether they will disclose their substance use or even be ready to have that conversation is sort of primed or cued by how receptive they feel in that healthcare system. So how did we build partnerships with sort of everyone in the system? I mean, I have to admit, we didn't, it was a journey. Part of it was having the peer navigators was really helpful to have their presence there, because they sort of embodied our program and were able to carry, use language. They weren't saying, using they were modeling behavior and attitudes and destigmatized language around the department every day. So they're engaging this population, and they're modeling how to partner with people with substance use disorder to everyone around them. They become these, they're sort of rushing in, being just super positive, energetic, excited, and radiating out this sense of a destigmatized interaction. They're also really well trained. They often have their own lived experience, and so through that, they people sort of recognize, and they witness that. They see the success. They see people start treatment. They see someone, receive buprenorphine and go from being sort of like just in this miserable place to being excited and happy to start on their journey towards treatment. That's one way. The other way was doing signage. We put up all kinds of signs around our department, you know, struggling with pain pills and heroin, ask for help here. So that was sort of, the signs are just plastered around the waiting room. And that was helpful to just have everyone sort of recognize, see those signs up and recognize that was part of the regular work of emergency medicine, that was a service that we offered. And then formal trainings, you know, outreach, doing trainings, having, we have annual competencies, baking in, you know, really simple trainings around language, you know, sort of words matter, that whole Words Matter campaign, and putting that information in front of all staff members at our hospital has been an amazing, has an amazing impact on how people, you know, do or don't carry stigma with them as they come to work.
So I'm wondering, how do you start a conversation with somebody who, say, is the guard in the parking lot, and encourage them to understand the work that you're trying to do and engage them as a partner? What does that conversation first look like?
Yeah, I mean, just, you know, I think it's one of these things where it's a conversation over time. Like most people don't have like well, some people have a cathartic sort of breakthrough moment. But by having the substance use navigators positioned in the ED, doing the work, and having the signage up, sort of you start to create an environment where this that carries through and starts to radiate out through your whole department. Another piece of this that's sort of interesting is we have Naloxone Distribution. So we have a low barrier Naloxone distribution program. And by having all these kits, so everywhere around the ED, we have these kits stored, and we're passing them out. And that we've been partnered with our security there's no, you know, it's not just restricted to the substance navigators, it's not restricted to the nurses. We've had any staff member or volunteer in our healthcare system can participate in that program. So by opening that up and bringing in security, like the security guards, into that program, it makes them think about why this is so valuable. You go through the training, they do it's like an online training. It's like an 11-minute video they watch. They start to see how they're having an impact on, we all see the overdose crisis feels like this sort of overwhelming and abstract thing. And once you're passing out naloxone yourself and being part of the solution, that changes attitudes amazingly. So we've had a lot of success with having our naloxone distribution program and having as many people as possible participate in it and be part of the solution and become engaged and invested in the solution, in helping our community. So that's been really productive.
That's really helpful. Maybe you touched on it a little bit, but it sounds like a lot of the journey that you and the other people in the emergency department have gone through has been stimulated or inspired because you have people with lived experience who are working with you side by side. And I wonder if maybe you might talk a little bit about how working in that type of an environment helps to normalize an understanding around people with substance use issues and helps to normalize a sense of dignity and a sense of humanity in working with people who need help and in one way or another are asking for help, but maybe can't fully ask for it. So if you could just talk for a moment about that, I'd like to know how the substance use navigators really help there.
Yeah, I mean, if you turn back the clock to sort of the status quo before we had the substance use navigators, before we were offering treatment, before we knew how to provide treatment in a meaningful way. The situation was often, so, you know, we had sort of a law enforcement kind of approach, and not in a good way. Like we were patients would be labeled drug seekers, and we were not having productive therapeutic relationships with people who had substance use disorder. We carried a lot of stigma towards that patient population. If we did sort of have our hearts in the right place, we didn't have any meaningful solutions that really would be able to change it. It was just, you know, it was like goodbye, good luck. There wasn't anything that we could do that was that productive. Despite seeing this patient population, you know, for instance, emergency departments are an enriched environment for this particular patient population. The more you're struggling with a substance use disorder, the more likely you are to end up in the emergency department, brought in after an overdose, or, you know, your health is failing, or you're having behavioral issues. You know, these, like the ER is one of the common final pathways of severe substance use disorder. And so there we are facing this population, incredibly vulnerable, has an enriched population of people with very high needs around substance use disorder. And we were completely unqualified to really treat this patient population in a meaningful way and provide meaningful sort of interventions. So what we found was by being, you know, it's one of those things where having a substance use navigator, they're a peer navigator in that environment. It's like being nice actually saves lives. Like having that understanding and compassion and connection with having the substance use navigator there taught us all as healthcare providers how to engage people who have substance use disorder, who are really struggling. How do you start those conversations? How do you really partner? How do you change something that has gone from an antagonistic, hostile relationship, a broken relationship, really? How do you make that into a partnership? And they really taught us a lot about how to partner and how to have those conversations, how to get you know, your interests aligned with these patients, and how to move there. And a lot of that is through the lived experience, the destigmatizing language. I mean, words really matter. And the troubleshooting, you know, so much of it is troubleshooting. You know, when you have substance use disorder and you're trying to get to treatment, there's like 1,000 barriers. There's no, you know, access to outpatient clinics, like in terms of when, yeah, they'll see you in a month. Meanwhile, you're going to be using heroin for a month, you know, and maybe your insurance doesn't work. Like, how do you even go about sort of finding treatment that's going to be paid for, and in a timely manner, and is going to be evidence-based and really high quality treatment? And these substance use navigators have learned through following each patient's journey and helping troubleshoot their journey along the way. They've learned the sort of the outside community, like what's available and what's working in the community, which clinics are really good, you know, and timely and are having success, and which clinics are really struggling and not meeting the needs of the patient. So they become these, you know, beyond just that one-to-one relationship they'll have with the patient, they start to develop this awareness of the entire community, of what's available out in the community and how best to access that community. They become these incredible resources. So we've been really happy with how that's played out.
Yeah, so it seems it seems that one of the end results of having a strong partnership with people who have lived experience, who become a part of your team, is that the team changes, and the team the team starts to understand the issues that the client has in a different kind of light. And I kind of like how you pointed out that in the past we've had a a bit of a, I don't want to say I don't exactly want to say law enforcement. We've had sort of the bad cop. We've been playing the bad cop in our approach to people with substance use disorder. You're somebody that I have to protect the public from. You're somebody I have to protect from themselves. And what you have learned through integrating people who have lived experience in your care team is to understand the issues on a more compassionate level and a more integrated level. I don't know how many people who are working in that environment who would understand all the many steps that prevent somebody from finding their success in in moving towards recovery, whatever that means for them. Without the experience of having that sort of daily interaction to learn a new way of thinking about the issues and the challenges that people face. So I appreciate how you described that. And I'm kind of wondering if you would maybe take a minute to talk about the Bridge program and, where it got funded, how it got funded, in a way that that could help other people who don't know anything about Bridge, and who don't really know about where the idea of incorporating and paying for and how people are paid for that are part of this program. So maybe you could talk about that a little bit.
Yeah, so California Bridge comes through the SOAR funding, SAMHSA funding that cascades to DHCS, our California Department of Healthcare Services. And these grants help support paying for substance use navigators to be positioned in emergency departments. So they help set up actually direct funding for their position. And so these are the peer navigators / substance use navigators. We also create content and resources for nurses, clinicians to be able to initiate treatment, buprenorphine treatment in the emergency department, and actually treat all substance use disorders, including alcohol use disorder, in the emergency department with the current evidence-based practices, and provide linkage. The Bridge part of Bridge is linking to outpatient ongoing treatment. So the ER really is the front door of healthcare, and we make that front door, connect seamlessly as possible to ongoing continued treatment through Bridge, through the Bridge. And the Bridge is basically having the substance use navigator continue coaching and supporting even after the ED visit. They make sure there's a warm handoff to their ongoing treatment, that they have an appointment, they have prescriptions, that everything works out of the pharmacy, that their insurance is sorted out, they're enrolled in insurance if they don't have insurance coming in, that the outpatient clinic is ready to receive them, that the clinic that they're going to is providing evidence-based treatment that's of high quality. So all these sort of issues are ironed out, and that Bridge is built in a robust way right from the ER to the outpatient treatment. So that was the fragmented system that our community faced. We started to work on a pathway to overcome all that and create a seamless system that is, on the face of it, like it makes so much sense. Like it's sort of, it's shocking really that it's so fragmented to begin with. And so, and the community doesn't quite understand how fragmented it is until they start to try and access services. So we just saw all the barriers that they were facing and tried to create this seamless pathway to from basically active use, uncontrolled active use, and to being in treatment. And then also creating, part of it too is having a low barrier where we know that patients are going to and clients are going to be fall out of treatment. Like that's part of the journey for many, many, many people, is that they're going to continue to they're going to return to use, and then they're going to be ready to come out of use, and we're ready to catch them. We have an open door. We're not the beauty of the ER is it's open 24/7. They're well distributed across the state. And so there just becomes this amazing safety net where you can always come right back in, and we will get you started again. We'll get you relinked and get this going. And because we've created that bridge.
One of the thoughts that came up from one of the audience members was just a question about, is this limited to people with opioid related issues, and how do you integrate people with other substance issues? And you mentioned alcohol, but I wonder if you'd speak a minute for meth, because meth is certainly even a more serious problem in many counties in California and across the country. So how is it different, or is it different for people who have an issue with meth?
So we there's also a lot of sort of co-occurrence. There's people who are using meth and fentanyl and alcohol. So I'd say the biggest tool in our toolkit is buprenorphine for opioid use disorder. That is the most, is the most profound impact, is the buprenorphine. For methamphetamine, the sort of mainstay of treatment that we initiate from the ER is mirtazapine, which is really helps people cut down on their use, and sorts out the associated sleep disorders that come with methamphetamine use. And then contingency management is we're working on, that's where we sort of connect them to treatment, where they would get high quality care with the contingency management piece. So that's the approach to methamphetamine. Interestingly, with alcohol use disorder, there's actually, I had a patient yesterday who many people aren't aware that there are medications that really help with alcohol use disorder. Just gabapentin and naltrexone are easy to prescribe, very easy, don't have a lot of contraindications or drug interactions. As long as they're not taking opioids, they can be on naltrexone, and just having it can have a profound effect on treating these patients. They've been feeling helpless. They don't feel like there's anything that can help. They're not aware that there's actually medications that can help. So it's a great relief that they can, receive these medications and engage with a peer navigator and get connected to ongoing treatment. It just, the same sort of elements of peer navigation and engagement, meaningful medications that are evidence-based and work. We sort of have a tool for each substance, and then you can treat them in tandem too, where you can start someone on buprenorphine and on mirtazapine and on gabapentin if they have alcohol use disorder. You can treat all these elements and add pharmaceutical treatment to each of these disorders that's helpful. And then, again, the peer navigation is just so powerful as to underlie all of that.
I just wanted to lift up something from one of the audience members. People forget that stigma is multi-level, self-organizational, and community. I think having embedded peer specialists also reduces the stigma, because they model successful recovery to everyone, even when on MAT themselves. And I just thought that was an important comment to lift up.
That is so powerful, because it's the it's one of these things. It's like, if someone doesn't have lived experience and they're, they just don't, that connection isn't quite as deep as someone who's really been there and is engaging someone who's really struggling. Is just, you can't replicate that.
Right. maybe you could just for a moment touch upon how you engage when somebody is in the ED, but they're not ready to address their issue of substance use. How do you form that relationship? How do you make that an opportunity for a partnership?
Yeah, so it's often the I may have like a social worker or a nurse come up to me and be like, oh, they're not ready for treatment. I'm like, okay, well, let me go talk to them. And motivational interviewing strategies. There's just and that's a whole like discipline. For me, I just it's very pragmatic and very troubleshooting in the sense of like, hey, I want you to be as safe as possible. So let's talk about safer use practices. Let's talk about having the Naloxone present. Let me give you these kits. I'm going to train you in on using these kits if you haven't been trained on that. I actually like to even give prescriptions like I recognize that right now you're not ready to start buprenorphine, for instance. That's fine. Why don't I do this? I'm going to write a prescription, and that prescription will be valid for 6 months, and you can pick up that, you maybe right now, maybe tomorrow, maybe in a week or a month, you're going to have a really bad, you may change your mind. And then, that prescription is waiting for you, and you can come back in anytime. So basically having, taking a harm reduction approach and providing safer use supplies, syringes, cookers that are, like having all that actually, just getting as many resources together as you can to help this person and meet them right where they're at, really engenders a trusting relationship where and what I often find is that people start to kind of ask more questions about the treatment and more about buprenorphine. Like even though that what had been a hard no turns into actually becoming interested, because that shows through your as you're trying to come up with solutions and really engage people with where they're at with their use, they become, that's recognized, and then they start to become curious about everything that you're offering, all the resources you're offering, and even just getting people sandwiches and refilling their blood pressure medications, like all those things where you really are just kind of really sitting right next to them and thinking about their situation and coming up with, getting a shelter, like what are all the things we can do? And then, that is universally recognized as, that you're in their corner, you're advocating for them as best you can. You have this incredible, assortment of things that you can offer, and whatever they're willing to take at that moment, they can take. But I try and build it in too, where it's like I give that prescription. I give, the more you offer and you really partner with them, the more they're willing to engage and go to the next step. And maybe even sometimes it's not even that time. They may come in a week and return, and then they're really ready to have that conversation.
So one thought, I want to sort of pivot over to the idea of thinking about substance use disorder as a chronic condition. And before we get into that, I want to ask the audience, maybe if they can put in a couple of their comments into the Q&A. We're interested in hearing from you about ways that you have developed some communication skill or some kind of key message that you might have used in order to forge a successful partnership around overdose prevention. There are so many issues here that we need to discuss, but I think one of them is in helping to sort of turn around anybody's perception that this is kind of a one and done, issue, that anyone who doesn't understand that substance use disorder is a chronic disease like diabetes, like many other chronic conditions, is going to misunderstand the reality in which the client, the person who has substance use issue is operating in. So I wondered if maybe you could talk a little bit about how you get other people within the healthcare system to understand that message, internalize that, and start to change their processes.
So how to sort of destigmatize your across the board, like how you bring everyone along?
What kind of support, what kind of conversations, what kind of strategies work in helping other healthcare providers understand this?
Well, part of it kind of sells itself in the so the successes that come from this, even just, I mean, in the sort of the patient journey through the healthcare system, where they when someone's in withdrawal, it is so uncomfortable, and that person can be hostile, just out of frustration and discomfort, and just miserable. They're just in a miserable, they're often scared, angry, devastated, feeling hopeless. There's a lot of hopelessness, and that hopelessness is palpable. And when you are successfully engaging with the patient, giving them buprenorphine, and then they feel normal for the first time in a long time, everyone in the care team sees that transformation. They see the substance use navigator, the clinician, the nurses engaging in a positive, non-stigmatizing way with this patient, and they see the transformation occur from someone who's feeling hopeless and miserable to feeling hopeful and feeling normal. And it just, you start to do that one patient at a time, and the people who are not, are surrounding that and witnessing that are pretty quickly transformed. So, it's like success kind of begets success. It's, there's not many things it's so profound. There's not many things in healthcare that have that dramatic of an impact, that someone walks in the door in one state and walks out the door in another state, like that powerful, it's just, it gets everyone's attention and quickly changes attitudes.
Yeah. So there's somebody here who said that what you're really doing is highlighting how you partner with patients in order to support them and meet them where they are. And, and for me, that it's just like another aspect of partnership. And, this is how we create a more resilient community. We connect with each other. We connect with people who are seeking help, who are seeking relief, and we help them as their partner to move into their recovery. The recovery part is big part, their part, but you partner with them to help them along in that way. Really good comments from the audience, and I'm not getting to all of them because I did want to encourage people to lift up a communication skill or key message that you've used to forge a successful partnership around overdose prevention, because not everybody's working in the emergency department. And so we know that the things, the skills that you all are using have developed are very important to share with other folks. So let me just lift up a couple here. Finding a champion within each department or organization seems to make a difference. I couldn't underscore that enough. I like the appreciative inquiry model to have conversations across groups that have different perspectives. It's important to be okay with having uncomfortable conversations to genuine conversations regarding stigma and closely held beliefs. Some really good comments.
Yeah.
Here.
I saw one comment too. Someone was having a hard time hiring substance use navigators because they were like finding people who were a really good fit for that role. One place that we found success is through the syringe exchanges. People who are working in syringe, that's been a great source of staff, because they're already in a harm reduction mindset. they know a lot. They come very well trained.
Yeah. And then here's another comment from somebody that I want to lift up. A key message that I have for individuals being served in New Orleans is the door is always open. Encourage people to come back as many times as they need, letting them know we won't give up on them and that we will support their needs. One of the most important messages that's out there.
Yeah, it's funny. We've had this, I mean, we keep like addiction, like access to addiction treatments, like this far off goal is the way it's been, sort of the framework is like, you have to, jump through all these hoops to get to this treatment. And so we've tried to just bring it all the way down, that low barrier, like, bring it right to where people are at, rather than having it be this thing that you have to earn. No, you can return anytime. We'll get you re-engaged, low barrier.
Yeah, thank you. I think this has been a pretty amazing conversation. We've gotten really deep into some of the issues that that you've articulated for us in the environment that you're working in. I want to remind the audience that there is both the video and the transcript that will be available on this website within a few days. So if you didn't catch a word or you didn't catch a reference or a connection, please come back in a few days and you'll be able to just download it yourself and share it with your partners. The other thing is I'd like to go to the next to last slide, please. And so on Tuesday, the 24th of May, we're going to have our next one, which is reach people where they're at. And let's go to the next one, please. So we want to know what it is that you want to know about, what conversations you want to participate in, what kinds of experts or what kinds of people with ideas or models that you want to hear from. So please let us know what we can do to support your overdose prevention efforts. The other thing is we want to know from you what works. And if you have ideas for programming, you have a model program that you'd like for us to lift up, please let us know. You can contact us at nop.org//contact. And there are more resources available for you if you sign up for our newsletter. Just visit nopn.org. And before we finish up, I want to just thank Josh for jumping in today and really courageously holding up this conversation. There's so much to share from your experience, Josh, and I think that people really heard the both the depth of knowledge and the heartfelt sincerity that you bring to your work, and we all thank you for that. So thank you, Josh, and thank you to the rest of our audience for being a part of this today.
Thank you for having me.